Hi, I'm Larry Mike Gorenda, and welcome to this edition of Excelsior Pharma Profiles. With us, continuing our medical research with doctors, is very proud to have him, by the way, is Dr. Ocean Thakar. How are you doing, sir?
Larry, it's a pleasure to be here. Thank you very much. I'm doing well. How are you?
Now, let's tell, you're a specialist.
Yes.
Let's talk a little bit about your training and education and what you really do.
Sure. Yeah, so I did my medical school education down at Drexel in Philadelphia. I completed my orthopedic residency, orthopedic surgery residency in Baltimore at MedStar Union Memorial. And then I completed a further subspecialty fellowship training at Mount Sinai Hospital in New York City. And so, long story short, what that means is I do kind of all of general orthopedics and some sports medicine, but my particular focus in my practice is upper extremity and shoulder and elbow surgery.
Now, when you say upper extremity, is it just the chest, just the back, or?
From the shoulder down, basically.
From the shoulder down.
Particular focus on the elbow and shoulder. Usually hand doctors take care of everything beyond the elbow itself.
Now, a lot of things can happen, especially, athletes have to be probably your number one. But also the elderly.
Yeah.
And people can just pull their shoulder out. I mean, these crazy accidents can happen with them. So what are some of the things that you've seen in this field?
Yeah, so with orthopedics, injuries and pathology can span a whole bunch of years and decades, right? It's not specific to older people or younger people. A lot of people now are active across the board, and so the more active you are, the more likely you are to kind of pull something, injure yourself, fall, and also wear out joints, which kind of leads to degenerative issues down the line as well.
Now, with the nervous system, a lot of people may not know how many nerves are running through that arm from the shoulder. Because, you bang your elbow, you're like, wow.
There's a whole handful. So it all starts in the neck with something called the brachial plexus, and from there it kind of fans out to the arm. And so you have 5 major nerves in the arm that kind of help you do most of the things, but there's a bunch of other ones around there as well. So
now, let's say somebody's working really hard, lifting.
Sure.
Okay. Lift something much too heavy, let's say 500 pounds or something like that. They hear a snap or a pull. Next thing you know, their arm is just hanging, they're in a lot of pain. What would you do for them?
Yeah, I mean, first and foremost, if something happens that acutely, I'd say you probably need to go to the emergency department, get an x-ray or something like that, or see me right away. Those types of things you don't want to miss, like fractures, pulled tendons or tore tendons, things like that. And so early on, depending on how they're doing, you'd probably, recommend that they trial some, assuming x-rays are negative and they don't have a fracture or something, you trial some over-the-counter medications like, anti-inflammatories and things like that. You do a little rehab. But if those problems start to persist and they really have a lot of pain and dysfunction, that's when you kind of have to start thinking about something more insidious going on and working that up further.
Now, what about some of the general problems that people have, like
Sure.
bursitis of the shoulder, elbow, stuff like that? What's the usual treatment? Is that called for surgery sometimes, or?
So bursitis is just a catch-all term for inflammation in the shoulder. What an actual bursa is just like a layer of fat that is between 2 pieces of bone that allow your tendons to kind of glide nice and smooth on one another. So when I move my shoulder around, I don't feel a catching or pain or anything like that. And so there's a lot of reasons for why someone would get some inflammation of that bursa, injuries to the rotator cuff, which the rotator cuff is just a series of 4 muscles that come and attach to the ball portion of the joint itself of the shoulder, allows you to power your arm and move it around. And so when someone has an injury to that or something else around the shoulder, it kind of kicks up this inflammation pathway. It causes bursitis. And typically those are not things that we operate on. Bursitis is really well managed with non-operative treatment options like over-the-counter medications and rehab.
Well, is it obviously it's possible to break your shoulder blade and your elbow, or chip it, right?
Sure.
So what would be the procedure for helping someone out with that?
Yeah, so if someone were to have a fall and break their shoulder or break their elbow, there's, it depends on the fracture itself or something like that, but those types of problems, not all of them require surgery, and depending on how shifted the bones are or where the fracture is, for example, if it's inside of a joint or close to a joint space, those things kind of push you further towards an operative solution. But a lot of times these fractures can be treated without surgery. You can kind of allow them to not do anything with the arm for a handful of weeks, about 6 weeks or so. Then you slowly start bringing in some rehab, and the body's pretty resilient, and so it will heal a lot of these fractures on its own. The things you worry about is making sure that it heals in the right way and it heals properly. And so if surgery can help make that more perfect, then that's when you kind of think about surgical options.
Right. And as far as like recovery time for some of these surgeries, is it, things have sped up before it used to be 6 months, everything like that. Has that calmed down a bit? Or?
Yeah, so we've had a lot of advances in orthopedics in general over the last handful of decades, and the instruments and technology that we have now is vastly superior to what we had in the past. And so a lot of the plates and screws and things like that we hold fractures together with are stronger. They allow for more minimally invasive techniques. All of these things lead to a more rapid recovery. That being said, bones are bones, and it still takes them at least 6 weeks to get sticky and heal. And so at minimum, you're not doing much with the arm for about 6 weeks. Then you slowly start letting these patients move their arm. You start strengthening their arm. And so by about 3-4 months, you're back to doing most of the things you want to do. And I've had patients on either side of that scale, right? A lot of people who heal a little faster want to get going. You tell them what you want, but they might get moving a little faster than other people. So it just depends.
And also, you work in Complete Orthopedics, so it's basically one call does all, because if you have a patient, he has a problem with his shoulder, but now he's having a problem with his hand or carpal tunnel or something like that,
Yeah.
we have somebody else on staff that handles that also, right?
Yeah, luckily there's 5 of us on staff, now 6 actually, and so all of us have our specific area of focus. My particular one is shoulder and elbow, but we have a hand surgeon who does a lot of other general things as well, foot and ankle surgeon, hip and knee replacement surgeon, a spine surgeon, so it's really a comprehensive place to come in if you have any kind of orthopedic issue.
Yeah, because I was going to say, sometimes if people are involved in an automobile accident or something like that, have a lot more than just
Sure.
a ripped up shoulder or
Sure.
or elbow.
Yeah,
or
and I
something
mean,
like
I'm
that.
comfortable managing a lot of that as well. Some of the specific stuff with spine and things like that I don't do. But, all of us are orthopedic trained. We've all done residency for 5 years in orthopedics as a whole. And so I'm really comfortable managing a lot of general orthopedic trauma and things like that someone may incur in an accident. But again, over time, I do want to build a more specific shoulder and elbow focus. Yeah.
Right. The good thing is that having all these other experts on your team, it's very easy for both of you to work on one person, stuff like that, and one call does it all, like I said.
Exactly.
Takes
There's
care
a lot of
everything.
support, and it's more convenient for the patient that way too. So.
Now, when we talk about the bones and the muscles and the tendons,
Sure.
okay, so if there's a problem with a muscle, surgery probably not necessary, or
So it depends, right? And so when you're talking about a problem with the muscle, what you're really looking at is a spectrum of issues that what we call basically, a strain. When you strain your muscle, it could be a slight pull, but even that slight pull is a little bit of a tear in that muscle or the tendon or where that tendon and muscle meet. And then you can get, different gradations of those tears where there are smaller tears that eventually propagate to a big one. And so each one of those types of tears has different criteria on what you have to do to manage it. And so if it's something mild, a lot of those things are you rest, let it heal on its own, then you rehab it to kind of get that strength back that you need. If it's bad enough where the muscle is torn completely or it's torn completely off the tendon or that tendon is torn off the bone, oftentimes you can't just rehab those types of things, particularly when it comes to the shoulder. So like a rotator cuff,
Right.
if you tear a rotator cuff tendon fully, typically you would want to manage that with surgery if you're someone who's younger, more active, but there's a lot of factors that go into making that
Right.
surgical decision with the patient.
Yeah, so when a patient comes into you with a problem, what's your evaluation? What's your toolbox that you use to help diagnose?
Yeah, so you got to look at the patient holistically, right? You know, we're all bone doctors. We love fixing bones and doing things with surgery, but you got to look at, you know, their medical history, the type of medications they're on. All those types of things matter in terms of figuring out what the best treatment for the patient is, because they all kind of help you get the right diagnosis. And so with any shoulder problem, the first thing you have to do is make sure you rule out an issue with the spine. There's a lot of overlap with spine issues and shoulder issues because of all those nerves we talked about earlier. And so there's an interconnection and an interplay of that, where you have to make sure that someone doesn't have a pinched nerve in the neck or something wrong with their shoulder blade, and that's not leading to their shoulder problem. Because most times when people have pain with their shoulder itself, they usually experience it on the outside part of the shoulder that radiates down to their elbow. And so that's kind of what clues me in on that's more of a shoulder specific problem. If they talk about numbness or tingling going down the arm or issues with the muscles around their shoulder blade, then you're kind of more worried about cervical spine or your neck being the problem. So that's the first thing you have to do. And then you really have to get an idea of, you know, what's wrong with the patient. Is it pain or is it dysfunction that's bothering them, or both? Because each one has different treatment problems or treatment modalities or treatment options. And once you figure that out, you really then need to dive a little bit deeper on what does the patient do? How old are they? Is this their dominant hand? What activities do they like to do? What do they want to get back to, right? And so that level of questioning for the patient really infers, you know, where we're going to start the treatment, whether we're going to start doing something more conservative or do we need to jump into a surgery because they're like, doc, I want to get back to doing this as soon as possible.
Now, what about special needs patients where, you know, of course you're going to do a full medical history when they come in.
Sure.
So like diabetics, people, osteoporosis, other things, all these other elements. So you're going to double check everything before, you know, to make a full eval, right?
Yeah, so depending on the type of surgery, 100%, right? So everything matters. Diabetes can help, you know, increase your risk for infection after a surgery. Osteoporosis can affect how strong your bones are, how well they'll kind of maintain the implants and things like that we're putting in. And so before you're ever considering a surgery on someone, you need to maximize or optimize all of these factors. And so their diabetes needs to be under good control. If they have heart issues, they need to see a cardiologist to make sure all those things are you know, up to date and well maintained. And then when you talk about osteoporosis, yeah, you know, we should definitely be doing, you know, preoperative blood work to look into calcium and vitamin D levels and albumin levels, a full holistic look at nutrition to make sure that they'll be able to heal well after surgery.
Right, and then also you have the precursor, which is osteopenia.
Correct.
Which can also add more trouble to any type of surgery that you might have.
100%. And the key, you know, in trying to limiting all of this is to make sure your nutrition's good, to stay active, to do kind of weight-based type of exercises to help build that bone quality back up. Go on any kind of supplementation if you need to. Oftentimes we've referred patients to endocrinologists to kind of work hand in hand with them to get patients' numbers up for their vitamin D and calcium and their overall bone density. And so all those things matter. A lot of times, you know, with the exception of fractures and certain things, a lot of these surgeries we do are elective. So we do have the time to really build you up and optimize you before we operate on you to ensure that, you know, your outcome is as best as it can be.
Now, with the high-tech medicine, of course, that's at Complete Orthopedics, you guys also do something called shoulder reconstruction. Now, this is what kind of, I'm like, how do you rebuild a bone? I mean, I just don't understand that.
Yeah, so shoulder reconstruction, a simpler way of saying that is like a shoulder replacement surgery. And so when we say reconstruct the shoulder, what we're really talking about is getting the anatomy back as best as we can to how the patient was before they started having problems. And so in order to understand that, we really need to understand about arthritis and what arthritis really is. And so our bones, and I'll use the shoulder for an example, the joint itself is a ball and a socket joint, and the surfaces of that ball and socket has something called cartilage on it. As you start to wear away at that cartilage for, you know, various reasons, you start to get bone rubbing on bone, and by definition that's arthritis. And unfortunately it's a degenerative process. It just gets worse and worse and worse. There's things we can do to manage the symptoms for arthritis, you know, over-the-counter medications, injections into the joint, physical therapy, but over time it will continue to get worse until the patient says, doc, my shoulder's killing me, I think I need a replacement. And by then, it's usually pretty bad. Right. So as you lose that cartilage, you start to get a lot of rubbing of bone on bone. It changes the anatomy of a patient. That socket doesn't look like a socket anymore. That ball is flat. It doesn't look like a ball anymore.
Right.
And so when we treat arthritis or cure it, the only way to really cure it is to cut out those arthritic portions of the bone and replace it with metal and plastic. You're basically just reestablishing that nice smooth surface so you can move your arm like you did before. But when you have all this deformity, when the bone has you've lost some bone or the bone has shifted or changed positions as it was, we reconstruct the joint as best we can, and we try to personalize that to each patient.
Yeah, 'cause now you talk about the ball joints, basically.
Yes.
The thing is, that nice and smooth thing, when you get arthritis, when it's magnified, and I've seen pictures of this, that nice smooth surface, you see little spikes and pits and everything else up on both sides.
Correct.
And if not handled quickly, all right, meaning this can really wear down in a quick amount of time, especially for older people.
Right. So, I mean, it is a degenerative process, and it will continue, and other things can accelerate that process. You know, if you have an infection, if you have a history of an autoimmune issue like rheumatoid arthritis, anything like that can kind of accelerate the degradation of a joint. So you have to keep that in the back of your mind too if you see a patient whose shoulder joint is rapidly deteriorating. And so all those things need to be worked up and ruled out before you operate on a patient. And then once you operate on a patient is when you can kind of figure out what the best implant for them would be.
Now, we hear the term reverse shoulder operation. Now, what do you guys do? Switch left and right here? I mean, it's kind of crazy.
Like the name implies, so as we talked about, the shoulder is a ball and a socket joint.
Right.
In a normal anatomic shoulder replacement, we replace the ball with the ball and the socket with the socket. With the reverse, like the name implies, we put actually a ball where the socket should be and the socket where the ball should be. And it sounds kind of crazy, but there's a reason for why we do that. And so it all goes back to making things personal for the patient. So 20, 30 years ago, most patients would get a normal shoulder replacement, ball with ball, socket with socket. But in order for that to be a successful surgery, you need to have a functioning rotator cuff. And as we talked about, the rotator cuff are the 4 muscles that attach to the ball and allow you to power the arm. And if you have an issue with that, where they're torn and all those types of things, the tearing of the tendon over time will lead to that muscle losing a good quality. It'll get infiltrated with fat, and then you no longer have a powerful arm that can move around, even if you did a shoulder replacement and got rid of the arthritic problem. And so about 20, 25 years ago, there was this invention of the reverse total shoulder arthroplasty, which was a game changer, to be honest, because it allowed us to replace shoulders and deal with arthritis and some other types of pathology without having a functional rotator cuff. And so switching that orientation of the ball and the socket allows you to use this big, powerful muscle on the outside of your shoulder called the deltoid to power your arm. I'm sure all the bodybuilders know what a deltoid muscle is, but it's that big one right here. And so if you don't have a functional a functional rotator cuff in your shoulder, then if you have a good deltoid muscle, there's still a viable option for you to deal with your arthritis, which we didn't have 20, 30 years ago. Or we did have some, but they weren't as great in terms of how well the shoulder replacement does.
Some of the terminology they use also is people constantly overworking a muscle.
Yeah.
Now, with the bodybuilders that you're saying, they rip, muscles rip, come back stronger. But if you have this constant overworking of a muscle, how is that going to affect the tendons, the shoulder, and the rest of the arm?
Yeah, some of this is wear and tear, right? The more you use it, the more you're likely to wear it out and have these types of things happen. Rotator cuff tears are degenerative processes overall. So what really happens is you start to get partial tearing of the rotator cuff throughout your life, kind of like fraying of your jeans when you start to lose some of those threads. Right. And then over time, that hole gets bigger and bigger until it's a full thickness tear. Patients don't realize that they have this, though, because your body does a good job of compensating for that over your lifetime. These tears are small and micro, so your other muscles get built up nice and strong gradually to allow for this. And then something typically changes where someone has a fall or they pull their arm a little bit more and that tear increases in size, and now they have increased pain, increased dysfunction. They come into the office and they say, "Doc, what's going on?"
Now, somebody comes into your office, and what are some of the tests that you're going to send them for if you believe that or suspect that they could be a candidate for shoulder replacement?
Yeah, so the first and foremost thing that we have to do when patients come in with any type of issue with the shoulder is get an x-ray. The x-ray will show us how much arthritis they have, if they have it at all, and what severity of that arthritis is, how much bone loss, how much erosion, all these things we talked about. They'll give you a kind of a snapshot picture of that. And then what you're really looking for when you see the patient in the office is, how's their function and how's their pain. Typically, is it bothering them during sleep? Can they, do the activities of daily living that they usually can? Can they reach up and grab some milk? Can they reach behind their back? All those things, if they can't do it and their motion is limited and they're in a lot of pain, and we've tried a whole bunch of other things, and we're really thinking about the surgery, and by other things I mean injections and physical therapy and all that, and they've tried it all and they're ready for a surgery, the next thing I would get is a CAT scan or a CT scan of the shoulder. What that allows me to do is it kind of gives me a high definition 3D picture of what the x-ray was showing me of the arthritis, of the three-dimensional configuration of the joint, where the erosion and bone loss is, where the arthritis is worse. And it also gives me a quick glance at what the rotator cuff muscle and tendon looks like.
Right.
And so if that all looks okay and on exam they have good strength with their rotator cuff, then I won't need to get an MRI. But if they have some weakness because of their rotator cuff might be injured or torn, and I'm worried about arthritis, then I might add on an MRI as well. Because like I said, if they don't have a good rotator cuff, then I can't do the traditional replacement. I would have to lean towards the reverse, and I want to know that before I get into the operating room.
Now, also, could there be something internally, like through their blood tests or something like that, that could show up that's going to make the situation either worse? Like I was talking about diabetes and some of the other things.
Yeah.
Would that play a big role in the pain?
Yeah, it can. I mean, I think if the one thing you always have to rule out before you decide to put metal in somebody is to make sure there's no infection, right? And so that sometimes some of that comes up in normal preoperative blood work. If you're worried about other things like arthritis or rheumatoid arthritis, and you should work that up as well, you should try to do as best as you can to manage all of the patient's comorbid or concomitant medical issues that they have along with their shoulder problem, right? The more you optimize all of those things, the better they're going to do. Whether it affects their pain all that much, I'm not sure how that ties into it in terms of diabetes, but a lot of times autoimmune issues can cause other problems in the shoulder too, and so you have to work those out.
Now also, at Complete Orthopedics, you guys do full personalized medicine.
Right.
And there's going to be a big difference. You have a woman come in her 50s, shoulder problem. Man comes in the 50s, shoulder problem.
Yeah.
How are you going to end up handling both of these? I mean, they have to get specialized, individualized treatment, right?
Yeah, Larry, that's a great question. And so the one thing that helps a lot with that is, especially when it comes to shoulder replacement, which is something that's relatively new and has kind of changed the game, is patient-specific instrumentation. And so for every patient that gets that CT scan preoperatively, I put it into a 3D computer software, and it pulls up their images in this computer software. And based off where their bones are, where the erosion is, where the arthritis is, and all that, I can kind of choose what kind of implant is best for them, and I can test it out on this computer model before I do it. And so if they have a good rotator cuff, and I'm thinking that a regular traditional shoulder replacement is the option for them, I can plan that entire case. I can plan what size ball I'm going to put in, what size socket I'm going to put in, the position of that socket based off their native anatomy, and how can I recreate their anatomy as best as I can based off things I do in the operating room. And all of that is done preoperatively. So for someone who's a smaller woman in her 50s, I would be much less likely to put a bigger implant in that person rather than someone who's a 50-year-old man who's a bodybuilder or something like that.
Right.
It also affects, I can plan both that reverse arthroplasty or shoulder replacement and the anatomic. I can see which one's better, and I can see which one might give the patient more range of motion because you can test that out in the software. I can see where they have extra bone or bone spurs that might be blocking their motion. I'll be like, okay, in the operating room, I need to take that out. I'll know exactly ahead of time everything I need to do in the operating room, because most of the things we use is off the shelf, but they're modular, meaning that I can pick and play from a lot of different pieces to put them together for the best implant for that particular patient. So I don't have to just approach each patient with the same cookie cutter approach. It's not the same implant that goes in every patient.
Right.
There's multitude of different variables that go into a shoulder replacement. There's at least 4 or 5 different factors that goes into that process in terms of positioning, in terms of angulation, in terms of all that kind of stuff that would give the patient the best possible outcome. And all that I can do preoperatively before I even get into the operating room. And I think that's really important. It's changed the game quite a bit.
Yes, this new computer software that you guys are working with over there is pretty incredible. Yeah. I mean, you can have like a picture of the person and actually build it before they're even in the operating room.
It's pretty awesome.
Which is that's
I mean, failing to prepare is preparing to fail, right? So the more you prepare, the less trouble you have in the operating room, because if you run into an issue, something's not fitting correctly, whatever might be the case, you always have plan A, B, and C in your back pocket before you even walk in. And so it's really invaluable for sure.
Yeah, because I mean, you don't want to have the person open up and then you're like, oh wow, this is the wrong size. And somebody run down to the hardware store and get me.
Exactly, and now and nowadays, a lot of this is still in the works. It hasn't been released for commercial use, but the one thing I love about shoulder surgery in general is that there's a lot of room still for innovation, and so people are trying to use augmented reality to bring up your plan that you've already made into the operating room, so that way when you're looking at the shoulder, you can superimpose your plan over the patient itself.
Right.
There's intraoperative navigation that we're using now too, to make sure that the placement that I plan where I want all my implants to be is perfect on the patient as well, because I'm using navigation with all these other tools and technology to make sure that it's placed exactly where I want it to be.
So basically, it's ultra precision surgery.
Exactly.
Before, where compared to even 10 years ago,
Yeah.
How the leaps and bounds made in medicine are just absolutely incredible.
Yeah, and there's studies to show that even being off by a few millimeters can make a difference, and so the
Right.
more perfect that you can be, why not strive for that?
Exactly, and with that type of computer and software in your toolbox, that makes for
Yeah.
a almost perfect operation for the person.
Yeah, for sure.
And the next thing has to be, is we haven't touched on it too much, but recovery.
Yeah.
Now we know about the surgeries, we know the computer and getting everything will get it for the patient, but a lot of people, they shy away from surgery when they should really have it because they're afraid.
Yeah.
And the fear should really be alleviated by now, because
Yeah.
with the new technology and the new techniques that are out. But the recovery time, a lot of people are like, oh, I can't be out for 6 weeks, I can't be out. The recovery times are pretty much remarkable now compared to what they used to be. It used to be have somebody out for 6 months. Now, less than 6 weeks. I mean, it's pretty incredible.
Yeah, so it depends on the surgery, and a lot of the advances that we talked about in implants, in minimally invasive surgery, and rehabilitation protocols have really allowed for us to get patients back to doing what they want to do a lot sooner, which is great. It always depends on the surgery itself, right? And so shoulder surgery in general has historically gotten a bad reputation because rotator cuff repair recovery in the past used to be very painful. Shoulder, replacement surgery used to be painful, but a lot of that has changed with the advent of new technology and treatment options and surgical techniques that we have now. And so typically for someone who I do a shoulder replacement on, you can expect to be in a sling for about 6 weeks, but we'll start getting you moving around the tail end of that. By around 3 months, you're really moving the shoulder all on your own and you're starting strengthening. And by 4 months, most people are back to doing a lot of what they want to do, which is pretty remarkable to think, big surgery, you replaced this whole joint, reconstructed it, and now they're back to playing golf in, 4 months or something like that. So.
And the same would go for the elbow, because both, like you said, the balls, the joints, everything like that.
The elbow's a little trickier. The elbow replacement options to date are not as great as the shoulder options, and so they do have a lot more limitations on what you can do and how quickly you can recover. Yeah.
So I guess it's better to fall on your shoulder than your elbow.
Yeah, if you had to. If you had to, I would say so, yeah.
Well, we're basically almost out of time, but the other staff that you have at Complete Orthopedics, it's basically a one-stop shopping.
That's right.
And it's good that, especially if you're in a car accident or had something seriously happen to you, that you could all be looked at all in the same office.
100%.
Which is pretty fantastic.
And there's about 5 or 6 of us. We're a great group of providers. We care about the patients. That's the number one thing, is patient-centric care. And like you said, you could get all of your orthopedic needs done by us for sure.
And it's personalized medicine.
Yeah.
It's not assembly line medicine, which we have been seeing far too much of.
Yeah,
lately.
the time is now to kind of change that, especially.
Right. So I wanted to thank you for coming on the show.
Thank you.
And if we get any more medical questions, can we bring you back?
Oh, I'd love to.
Our shoulder expert.
I'd love to come back. Yes.
Okay, fantastic. Until next time, I'm Larry Mike Arinda. Take care. Have a great winter. We'll see you soon.